I would like to introduce everybody to today's speaker, John Bain. He is a senior consultant at Stroudwater Associates in Portland, Maine, and he has over 15 years of experience in healthcare financial management and consulting. His focus has been on Chargemaster auditing, revenue cycle initiatives, as well as hospital and physician practice management. John has led initiatives to increase physician and departmental productivity, implement physician-specific and hospital-wide revenue cycle protocols, and develop Chargemaster maintenance policies and procedures. He has had success in growing gross revenue and net reimbursement through combining operational improvements, Chargemaster effectiveness, and efficient business office protocols. Prior to joining Stroudwater, John was the Associate Director of Revenue Control and Payment Systems for Leahy Clinic in Burlington, Massachusetts, and John earned his bachelor's degree from Boston University and his master's in Public Health Administration from Suffolk University. So John, I'll turn it over to you to share your webinar on Chargemaster fundamentals.
Terrific. Thank you very much, Leslie. And I'm coming through clearly and you can hear me?
Yes, I can.
Terrific. Always like to make sure because I can ramble on for a while and no one can hear me. So, well, good afternoon. I hope this finds everybody on the call well. When we started talking with RHPI about trying to put together a series of webinars that might be useful for their membership, what we tried to do is, in thinking about this was come up with a series of presentations that really would address what we find when we go to most hospitals that maybe might be able to give you guys some of the tools that could make it so that you can kind of build that fundamental relationship within your facility. And generally, one of the things that we find is that in a lot of hospitals that are kind of struggling or just are making their way through, but are having issues, whether it might be in denial management or revenue capture, or the business office maybe isn't as efficient or productive as one would hope, or everyone sits around in some of the senior management meetings and everyone tries to answer the question, how are we doing? Are we doing as well as we'd hope? And everyone looks at each other and says, man, my gut tells me, for everything that we're trying to do with our volume and everything else, I just feel like we should be doing better. And a lot of times that comes down to the fact that, as we all know, healthcare is a ridiculously complex entity, and we do everything that we can do in the operation of healthcare to make it more complex and more variable. So what we've been trying to do with a lot of our clients is really get back to basics, get back to things that can make sure that as we sit in a meeting, we can tick things off and we can say, you know what, this is in control, this is in control, this might be a little bit out of control, we have to address this X, Y, or Z. And what we wanted to start with was, let's really take a look at, from a baseline standpoint, our Chargemaster, okay? Realizing that everyone on this call understands what the Chargemaster does and understands what it's supposed to do. What we find is that when we go into most institutions, we get beyond the group that's maybe on this call today, and we start getting into the hospital. There's fewer and fewer people who understand not only the intricacies of the Chargemaster, but ultimately the responsibilities that it holds to either garner a positive margin or cause our denials or prohibit our financial success. So we designed this presentation specifically to give you guys, and a lot of this stuff may be redundant for some of you that are on the call, but the goal really is to make it so that you have a document that you might be able to utilize in talking with some of your departments, or use it as an educational piece to explain some of the components. Because ultimately, and anybody that, and I see some folks that we've had the privilege of working with in the past that are on the call, one of the things that you guys would know from dealing with us is that we are really proponents of ownership and accountability at the area that creates the charge, so getting down to the departmental level. And a lot of times we have a lot of angst in most facilities of allowing people to do that because it's a control thing, you know. A lot of times it's a quality thing, and that's fine. But a lot of times it's a control thing, and we don't want to get people involved because then I start losing control of the situation. So we've developed this presentation to try to see if you might be able to have another resource, and this may answer some of your questions about different things that you've had issues with in the past, but also use this to be able to pull things together, get people on the same page, and be able to start getting things out of the ownership of either the CFO, Director of Business Office, coding as far as the people who own the Chargemaster, and get it down to radiology, get it down to the lab, get it out to the ED. So folks that have dealt with us in the past, this slide should seem very familiar to you. Chargemaster is the tipping point. It is the tipping point on whether we're going to be successful or we're not going to be successful. You have to ask yourself, am I in my facility set up to know specifically that my Chargemaster is contributing positively to our financial viability? Or is it a hindrance? Or is it something that I have to work to go around? The majority of facilities we see, it's the latter rather than the former, okay? And so that's one of the things you guys have to think about. Now, the Chargemaster, it is only as good as our front end and our back end. It is, you know, for the most portions of things, the Chargemaster is, you know, it's kind of stupid. It does what you tell it to do. A lot of people look at it and say, well, the Chargemaster will fix it. You know, you say, how? It can't fix anything. It's going to have to be interpreted and modulated by you, okay? So you have to ask yourself, if I am the CFO or I'm the Director of Business Office and I'm responsible for the Chargemaster and I do all things, descriptions, revenue codes, prices, everything else, but I'm doing it for the lab, do I know lab better than lab? Chances no. You know, I go to the facilities and my hope, quite frankly, is that when I sit across the table from the lab director, she should know more about this stuff than I do. The problem is she doesn't know that she knows more about it than I do. So it's critical as we go forward. Keep this in your mind. It's a balancing act between the front and the back. And you can describe whoever you want to be on the front end and the back end. It's different at every facility. But to keep the mentality of the Chargemaster is the tipping point. And it's the tipping point of whether we're going to be financially successful or we're going to create and contribute to our own demise. So what's the role? I mean, so you have to think about this. So we're in our facility. What's the role of our Chargemaster, okay? So at a bare minimum, you know, Chargemaster is the communication mechanism between your facility and the payers, okay? I think we can all pretty much agree to that. All services must be conveyed using the most appropriate 5-character procedure code, either numeric CPT or alphanumeric HCPC, right? So that makes sense. It should be linked to the appropriate revenue code in the service for the service billed, okay? Compliant, accurate, and complete billing and reimbursement is dependent on the Chargemaster. That is something that your CFO, your CEO, your Director of Business Office, chances are they understand that. They've got to make sure that the rest of the facility understands that. It is only as good as the participation up and down the cycle, okay? So everything that we gear towards, a lot of the times that we see rack letters, we see denials, a lot of this stuff is entirely preventable and a lot of times is caused by the Chargemaster. So make sure that you can always answer the questions, you know, in an affirmative standpoint. Do we do these things? Does my mission for the Chargemaster reflect at a minimum those 3 bullet points? And hopefully it does, and it is representative of how you do your work. So what are we going to do, okay? So as we're going through here, we're going to try to go through and we're going to review the components of the Chargemaster. We're going to understand the individual components and the role of subcategories within the Chargemaster. Second thing you have to ask yourself, do I have a billing system that allows me to drive the Chargemaster like a Ferrari? I've got every bell and whistle and, you know, it's got a beautiful shiny red apple color. It's a beautiful thing. But do I drive it like a beater Pinto, right? The majority of facilities don't utilize the Chargemaster as it was designed, right? We change things, we make it so that we, you know, our complexity of our hospital deems that I have to change this and then make it so all of a sudden that I put all these limitations in and I'm driving the Ferrari, at 5 miles an hour and trying to drive it like a Pinto. You shouldn't be able to do that. So you have to ask yourself, how are we driving this? Do we understand and use all of the categories within the Chargemaster to our benefit, or do we ignore it because it's hard? Okay? We've got to examine the Chargemaster's impact on billing, reimbursement, and compliance. It is intricately tied. Okay? You can't get away if your pricing's wrong, if your Chargemaster is screwed up from assignment of HIC picks, revenue codes, whatever. If that's wrong, we can't sit down and say, oh, we're getting paid everything that we should. Okay? What do we normally do? We, in a lot of hospitals, will turn and say, oh, it's the billing office's issue. Well, the billing office may not have any ability to change or update or augment or even understand that it's the Chargemaster that's causing the issue. Okay? So make sure that everyone, including you when you sit in your meetings, understands that this is what we're talking about. We're talking about compliance, gross revenue, and net reimbursement. The tipping point is the Chargemaster. We're going to work to real quick outline a process of checks and balances and continuous auditing to ensure a healthy, compliant Chargemaster. Remember, this is a living, breathing thing. It is something that changes almost daily. It's something that is dependent on food being provided to it in the types of information that you're going out and getting, and you're getting root cause analysis from denials, which is making it so that you can intelligently change the Chargemaster to more compliantly reflect the services that are billed. Don't look at this thing as a static thing. Don't look at this thing that the only time we care about it is when we're going to go and add 5% across the board because it's September 30th and our new fiscal year is October 1st. It can't be. Someone's got to be looking at this and thinking about this on a daily basis. So let's think about this. At a very bare minimum, code sets required for facility billing, right? We've got our CPT, our HIC pick, our revenue code, our ICD diagnosis codes, procedure codes, and our modifiers, okay? At a bare minimum, everyone in your organization should at least understand what these things are. The majority of hospitals I go to, departments barely understand what a CPT is. They have no idea what a HIC pick code is. And if I start saying things around revenue codes, they look at me in this blank look, okay? And you look at it and say, okay, so who is assigning all of these things? And a lot of times they say, I don't know, or say it's the business office, okay? So it is incumbent on us to educate the people throughout the cycle to understand what these things are. And once you explain revenue code assignment to, say, RAD or lab, it makes more sense to them than it does to you because you start saying, is this lab a chemistry lab? They know immediately what you're talking about versus us sitting around going, I think it's kind of a chemistry lab. I don't know. So at a bare minimum, people should understand that these are the bare minimum components of our code set for the facility, okay? Now, a lot of times, we talked about this a couple seconds ago. The Chargemaster in our billing operations, it's really like launching the space shuttle. It's complex. I've got all of this stuff going on. This interacts with this, and if I go left, then I'm going to get this code, and I put all these wonderful multipliers in, and, I talked with my billing guys, and what they did is they pulled this thing together, and these codes explode and do all this other stuff. So when we sit and go and say, from a Chargemaster standpoint, it should be a relatively simple diagnostic thing to go in a set of dominoes and we just knock them down per procedure and this is where we go. Really, when we look at it, it looks more like this. It looks more like we're trying to launch somebody into space when really we make it more complex than it needs to be, okay? Ask yourself, do we make our process more complex than it needs to be, or are we setting the foundation based on simple, consistent methodologies that make it easy? Can I put my policies in place and write them down on one piece of paper? Or do I need a diagram like this to be able to say, how do you bill a PSA? When we start looking at the Chargemaster, okay, a lot of times, and I'm always surprised, when I go and I make some phone calls and try to start working with some facilities, I have to start defining the file size and the components of the file that I need to be able to just take a look at it and see how they're doing, okay? So it always kind of it's very instructive to me of how the facility looks at things because a lot of times they've never downloaded the Chargemaster. But these are the same people who tell me that their facility is in control. And you look at in control compared to what? You don't download And when you do download, you don't have any of the components that you actually need to look at. So at a bare minimum, I can do an awful lot. So everyone on this call, if they just get their report, okay, to download these fields on an ongoing basis, you'll be able to take almost immediate control of your Chargemaster and at the same time be able to find problems that'll scream out at you just by looking at the fields. Okay? So at a bare minimum, you need to make sure that you get your item number, you get your description, you get the assigned revenue code, the assigned CPT or HCPC. You may have multiple fields, one for CPT, one for HCPC. The charge amount. You may have alternate CPT or HCPC code fields that are available. The department, and then the GL. Okay? When you get that down into Excel and you put it into somebody, certainly that's on this call, to manipulate and review, all this stuff starts falling off the plate. So you have to ask yourself again, do we have the ability to run a report that is at a minimum going to give me these fields? Now, the thing I get into big fights with a lot of the billing companies is that this should be a difficult thing. I argue with them all the time. This should be a core report that no one should even ask you for. You know, you should be able to have that as a menu on your item on your thing that, boom, you download it, it goes into a text or an Excel file. You're able to do whatever delimiting factors you need to do, and you can see these things on an ongoing basis, okay? So ask yourself, do we have the ability to do that? If the answer is yes, ask yourself, do we? What do we do with the data? Do we look at it? How frequently do we look at it, okay? So it should be a normal part of our process, and in our auditing, it starts with the ability to get the file into a workable format so that we can do something with it, okay? So take a look at your things. If you don't have all of these components, really you should go back and find out how you can get those added. I like this setup just because sometimes, when I'm sitting and talking with, say, lab or rad or, the ED or someone, and I have to try to get them to understand the differences between CPT and HCPCs, it's subtle, okay? But at the same time, sometimes people look at this and can see that there is a difference, okay? And we all know CPT is the major leagues and HCPC is the minor leagues. It is what it is. CPT changes a lot less frequently than the HCPCs do. And the HCPCs generally cause more problems from a billing perspective because not everybody wants them, and we realize that. So, we start getting into a match between whether we use at the payer level the CPT or the HCPC. What I would do, if I'm looking at things, and I think that I'm doing well with my my CPT and HCPC understanding, and this is a test all the way through. One of the things, if I'm leadership, I'm going to go and I'm going to ask simple stuff. If we do endoscopies or colonoscopies, find out who wants the screening codes, who wants the CPT codes, right? Have them put it down. It's almost like a test to get to your billing office. Have them bring that back to you. You want to know from a screening PSA. You want to know the same thing for, say, your observation. Who wants the G? Who wants the CPTs? If the billing office is tuned in and is really good at what they're doing, it will take them no time whatsoever to get that information back to you. If they look at you like you're asking them to figure out, how to take this pen and hit the moon with it, you know that you've got an issue. Because as you're looking at that, you say, how do you know if the claims are being paid right? Because it should be hitting them in the face. If I'm sending, a G code for a PSA and it's not even on the fee schedule for Blue Cross for me, I've got to send the 8. What are you doing with that? Are you just adjusting it off? Something simple that's controlled by the Chargemaster can then fix your denials. So use this. Ask the question. Figure out what the knowledge level is of people who are using the output of my Chargemaster. Remember, living, breathing thing. People find out things through exterior sources that are coming in through denials, letters, whatever it might be, and then am I using that to update the Chargemaster intelligently to make my life easier? Remember, our goal all the time is to make sure from a departmental standpoint, we put the business office out of business. How do I do that? I ensure clean claims. How do I ensure clean claims? It's an educational process that's coming back to the front to make sure that I can change things, make sure that the same issue doesn't happen over and over and over again. The majority of people on the call will probably say, we all have things that are the same things over and over and over again, and I just wish I could fix them, okay? So use this as the beginning to have that start conversation, okay?
John, One of the participants asked if you could speak just a little louder because they're having difficulty hearing.
Well, that's a first. I don't usually get very much that people have a hard time hearing, so I'm sorry about that. All right, hopefully this is a little bit better, okay? So now we go into the CPTs and the categories of the CPTs. Again, you put this to your coders, it makes sense just like that. Business office, maybe not so much, okay? So absolutely, let's make sure that you go through and you start asking the questions, do you understand the ranges? So when I'm looking at the account, okay, so do you have your billing people adjudicate accounts proactively? Do they look at the account and understand that if they see an 8 series code, that that is lab? Do they understand that the 7s are rad? Okay? Simple stuff, okay? But do you understand that, okay? If they do, they're going to have a better job of proactively addressing things, and they'll have a better idea of being a profit center rather than a cost. Ask yourself, how do I look at the billing office? Is it a cost or is it a profit center? Guys that have really good profit margins treat the business office as a profit center because they are going and making adjustments to the Chargemaster based on things that they're finding through denials or publications that are coming out. Same thing for the hit picks. A lot of places don't have any idea of all of the opportunities, right? So I'll go into hospitals and they'll give me, you know, it's like an alphabet soup. Someone has spent hours and weeks going through and putting A's and B's and C's and M's and R's and S's and T's on anything and everything. Then I start talking with the person who did that, and they're like, all I know is I just have this book that I went through and tried to find things, okay? So, but they didn't even have the categories laid out for them so that it could make sense to them, okay? So the question is does the person who's doing your Chargemaster, okay, they should have this type of table right available to them. If they don't, are they just looking and trying to page through the HCPC book? Are they doing it on their own, or are they bringing things back to the departments? Advocate always for bringing things back to the departments, okay? So a lot of you on this call, this should make a lot of sense. It should be something that you see all the time, and you should almost be able to recite the alphabet soup, you know, because you know that all these different things go. If you don't, that's fine. Use this as an educational piece to try to figure out how do we implement that to try to increase our training at the facility level. So simple stuff. So you have to understand as well, the Chargemaster must maintain all CPTs and HCPCs used within the facility and provide accurate differentiation between codes for proper identification. Okay? So this is where we start, when the rubber starts hitting the road. You know, for example here, so I'll go into some places where we'll do a lot of endoscopy and colonoscopies, and they'll assign one code. So I'll look at the Chargemaster, and there'll be like one code for a service. And you look at it and you say, guys, do you only do this service? Yes, but it turns out that they do all these different types of services. So, for example, there are 22 CPT codes that represent the upper GI, right, for an esophagus to jejunum, okay? So you look at that, and we start taking a look at the CPT description, and it moderates, right? So you have to ask yourself, how do CPTs get into my billing system and into my Chargemaster? Who's looking at these things? Do they understand the subtle differences between what's in the CPT book? Okay? Hugely, hugely important. Okay? Because we always need to make sure that the service that's being represented is best represented by the most specific and complete CPT assignment. Okay? So do your policies and procedures. Ensure that that happens. Take a look at your system. If you've only got one CPT in this range, ask yourself, is that all we do? How do you know? Do you trust the fact that somebody else knows? Okay? Always ask the question. Push back on everybody, right? Get people involved. Have coding try to defend the fact that they only have one code. Chances are that's incomplete. Wow, I got dizzy there. So closed treatment for a fractured toe. Here's all of the different codes that are in the area of a fractured toe, okay? I go into a lot of hospitals that have, again, they've got a pretty vibrant ED and they've got an ortho that kind of works intermittently out of their OR, and I'll have 2 codes that they use universally for a fractured toe. And you start pulling in and you start doing chart review, that's not even close to being able to go through and reflect the variances in the services. So a lot of times people don't want to do this because they say, oh, it's too complex. The problem being is that you need to reflect the services at the best level of specificity available, okay? You're going to add things. It's not a bad thing when your Chargemaster grows, okay? If you do this and you review things on a continual basis, ultimately it will become more specific. You'll reduce and get rid of a lot of stuff that you don't need, but it will be more specific. Chances are, if you do a lot of orthopedics, you need more codes than this to reflect the services that are going. Ask yourself, do we look at it? How do I know if I'm in a position of leadership? Do I trust and verify or have hope and faith, right? Ask yourself. Departmental leadership, in conjunction with the business office and medical records, should identify all CPTs added into the CDM. At a baseline minimum, that needs to happen every single time. CDM should be complete and accurate for services provided within any fiscal year. Okay? No duplicate or redundant entry should be made. Ask yourself, if you've got some codes that are in there 14 times, why? Why do you have, procedure code 12345 chest x-ray? Making it up, okay? In there 16 times with 15 different fees and 12 different definitions in the description. Ask yourself, why? It's a chest x-ray. Why do I need chest x-ray Wednesday, chest x-ray Friday, chest x-ray man, chest x-ray woman? If you look at some of your descriptions, even though we're kind of making fun of it, that's almost to the level that we're creating the Chargemaster. That's silly, okay? So get rid of the duplicates. We don't want redundancy. All codes should be examined at least quarterly, right? We got to identify deleted codes. Happens routinely on our HCPCs. Got to look at our utilization. You asked me to add these 5 codes because you said you were going to use them. In the last 4 months, we've used them 0 times. What's wrong? Did you not use them? Did the patients not get scheduled? Or did you think you used them and we just didn't bill it correctly? Oops, I've got 5 different people adding codes in there. Oh, we added 3 of the same team because they asked Mom, Dad, and Aunt Mary because I needed the code very quickly. And Mom, Aunt Mary, and Dad all added the code. And look at that. We have 3 different revenue codes, 3 different descriptions, and wait for it, we have 3 different fees. Awesome. And then it's the same thing. You guys will look at me and say, we're in control. We're good. Yeah, you're not. Come on, let's be honest about it. What process do we have to make sure that this doesn't happen? Codes with no utilization should be reviewed for possible inactivation. It's not a bad thing to inactivate things. They don't disappear forever. They just go away from the use of being available. We got to look at it from a coding perspective, business office and finance, and departmental leadership. Not one person by themselves should go through and say to themselves, well, I'm just going to inactivate these. No, it's a group think. Okay? If coding and business office say it should go away, but the department says, what do you mean? I do this every day. Oops, wait, stop, step back, flag. Right? Get the communication there. Most facilities, okay, when we go in, there is no communication between coding, business office, financial, departmental leadership. Right? Everyone sort of thinks that everybody knows what each other is doing without communication. So we've got a lot of, nonverbal communication, looking at each other and saying, you must know that I'm thinking of deleting 784.65 because we haven't used that, right? They have no idea that you want to do it, and you don't know, quite frankly, that if you take that code out, you just rip the guts out of her RAD system. She's going to have to go and change all of her order entry, right? Talk. Make sure that you've got communication. Maintain only what is currently used or likely to be used. I'm really, I like this at a yearly basis, but at a minimum, you should probably do this biannually. Take a real good look at this on a biannual basis. Alternate CPT or HCPC code selection, right? So many CPTs and HCPC codes overlap, right? Payers may require different codes to represent that same service or supply, okay? Everyone on the call should know that. Again, it goes back to the screening or non-screening codes. Ask yourself, does my facility have any idea about this, and what's the likelihood that we're doing this correctly? Alternate code options should be specific to one option or payer. This is where we start talking about driving the Ferrari like a Pinto, right? So if I've got all of these different options, do you have the ability to name them? Medicare, Medicaid, Blue Cross, commercial, whatever, or do you just call it CPT 1, CPT 2, CPT 3, and then hope that everyone understands that 1 is Medicare, 2 is Blue Cross, except on a Friday when it's really Medicaid, and CPT 3, I have no idea. We've never gotten that far, right? So ask yourself, how do we use it? The alternate code field should be named to ensure the accurate and consistent assignment. If you don't currently do that, go back to your vendor and ask them if you can. Most billing systems have the ability to do it. That's not launching the space shuttle, so use it if you can. Create claim logic to assign the hierarchy and only populate alternate codes that differ from the main options. So many of you have claim logic that by payer will say, oh, I've got a Medicare claim. I'm going to go and populate first thing from the Medicare field. Oh, I have a Blue Cross field. Ooh, I know that this one always wants the alternate HCPT code. And it goes by payer. It can look at a whole bunch of different things and let the claim logic dictate on a consistent basis what field it goes and populates. Okay? Don't have it so that somebody's making the decision on an as-needed basis. Research it, figure out if your system can do it, and then let the system do what it does best by using rules to make sure that it can make sure that it is adjudicated correctly. Okay? So at a minimum, payer-specific CPT HCPT. The alternate code should only be populated to identify a requirement that differs from the primary code selection. So when we start looking at it, if I'm set CPT up as my primary and I've got the ability to set up my alternate code hierarchy for Blue Cross, Medicaid, commercial, whatever, we should only use it for those things where it's going to differ from the CPT. Okay? That makes sense. Okay? Alternate code maintenance. Okay, so once I set this thing up, it's got to be maintained. Why? We all understand that the alternate codes, the HCPCs, change a lot. They change frequently, right? So if they change frequently, there may be the time that they may get denied, they may become deleted. If they start getting deleted, then we've got to make sure that we've got the ability to make sure that we update the Chargemaster, because God knows there's nothing like a good denial from sending a deleted code. Right? I have not really ever seen a payer go and pay the deleted code. If they do, they're going to come back and get it from you, right? So that really involves a quarterly review at a minimum with your departmental leadership, your coders, and your business office, okay? So ask yourself, does that meeting ever happen? Or does it happen where I've got, the business office just making changes? Who has the ability to make those changes, right? Ask yourself all these questions, because this is how you decide whether it's working the way it should, or am I getting the results that I deserve, okay? Revenue codes. A lot of times I go in, and you won't believe the amount of people that have absolutely no idea what I'm talking about. And in a lot of facilities, there's one person that knows, okay? And they're making decisions on the revenue codes for all these things, and they don't really fully have an understanding of how the revenue codes work. So ask yourself, look at your Chargemaster. You can tell very quickly, look at the lab, pull up and download your file, take a look at the 800 series codes. If all of your codes are set at 300, someone decided to use the most generic code. Chances are that's not the department. If I lay out all of the revenue codes for lab and give the department the opportunity to make the distinction, it'll take her no time at all to say hematology, micro, chem, pathology, immunoperoxidase. They'll just go like that. So you have to ask yourself, who's doing the revenue codes? I like this screen just to go through and provide so that people understand why we care. Right? So there are 3-digit codes which categorize the type of service or product delivered, describe where the service took place and or who performed or is billing the service, professional or technical. 450 ER, technical, 981 professional, right? All procedure codes must be billed, in a hospital setting. The UB or the 510 claim forms must be paired with a revenue code. Simple stuff, simple billing logic, right? So people don't pay an awful lot of attention to revenue codes, but at a bare minimum, you shouldn't be able to even get a code out the house without a revenue code. And then if you do the wrong ones, many payers are getting smart to it and are starting to go through and deny claims because of procedure CPT revenue code mismatch, right? Revenue code, procedure code pairing must make sense, must follow the National Uniform Billing Committee guidelines, and must be acceptable to payers. So how does the CFO know if this code is going to be acceptable to payers without talking to the business office? How does the CFO, if they're responsible for the revenue code assignment, even know that the National Uniform Billing Committee has guidelines? Okay? Ask yourself. Whoever's doing it, find out if they even know that this stuff exists. Revenue code HCPC mismatches are automatic denials in very many cases, right? So am I creating a situation where I'm creating my own denial management problem? Many times the answer is yes. So here's a simple example revenue code categories when we start looking at things. Very simple stuff. We've got the 250s, the 25Xs, which are our pharmacies. We go to IVs. 27s are supplies. This should make sense. If this doesn't exist anywhere in your facility, ask yourself why. Okay? If it doesn't, just copy this out of your packet and put your header on it, and that's where we start using it from. So start investigating and allowing the lab or diagnostic rad to use this to make sure that their appropriate revenue codes are assigned. It's not hard. It just needs to be educated and trained to your people. Why do we care? Right? So a lot of people say, what do I care? It's just 3 digits. I just like using the generic one. It's fine, right? So proper revenue code assignments allow the payers to apply the correct reimbursement schedule. So here's one of the codes that we saw before, right? So we're going to use some of these codes throughout the rest of this. So 432450, okay? So if I'm using it in the hospital for minor surgery, endoscopy suite, or the ER, I can have 361, 750, or 450, right? So ask yourself, there are payers that are out there for colonoscopy and endoscopy services that want 750, right? Do you even have 750 as an option in the Chargemaster? And if it's not there and you know that Blue Cross wants 750, is it in the claim logic? Prove it to me. Print the UB for Blue Cross so I can see the 750 on the piece of paper, right? So here, when we look at this, when Medicare gets those 3 revenue codes for that CPT, they pay $611.73. Right? I go to an RHC or an FQHC with the 521 or 520, all of a sudden, boom, different reimbursement for the professional side. Outpatient hospital or endoscopy suite for professional with a 982, boom, a different one. ER 981, same one as the 982. Things matter, right? We can't just use the, and just say it doesn't really make that much of a difference. It does. We need to be as specific as possible. If you're going to do it, at least take the time to do it correctly. Make sure that it is as accurate as possible. The billing guidelines state that the revenue code assignment should represent the most specific code available to identify what? The service performed, where the service was performed, and by whom. Medicare guidelines require that the revenue code reflect the cost center where the procedure costs are reported on the cost report. Ask yourself, at a minimum, when we're assigning the revenue codes, I'm not sure what that happened there. Leslie, are you able to still hear me?
Yeah, it just cut out just for a second.
Okay, terrific. Oh boy, and I said something really great there too. You got to make sure, at a minimum, whoever's assigning the revenue codes has that specific guideline around. How are they making the decision? They should have a decision tree and a source that makes it so that they can end up with the right codes, okay? Simple stuff here. We started looking. It's the same code, the 43250. Here's all of the possible revenue codes on both a hospital side and if I'm billing professionally from a facility standpoint, all of the opportunities that I might be able to use for that specific CPT code. So this starts to get into why when we go into most facilities, when they just have one person that does everything, okay, it's just like having that one person that we talked about last week that's doing the ICD-10 implementation. They can't do it. They need help. I don't know why we have to be the last soldier standing. There's a lot of people in your facility that understands an awful lot of this stuff that can help you make the decisions and be quicker and be more accurate. But for some reason, a lot of times we don't do this. We just try to do it in a closed room because we can't bother and they never respond, but maybe we're asking the wrong question. You need help when it comes to setting these things, especially when we start getting into labs and rads and stuff like that. So the business office, how do we go through and make sure that, one, we've got the right revenue code assigned, but even how am I going, if I'm creating a new procedure code, how do I make sure I do it? right? So the business office receives a request from a departmental leadership to add a CPT or HCPC. Now, for your hospital, change business office to CFO or coder or, Sally, who's there every Tuesday from 9 to 4, whoever, okay? Our request, when we get them, regardless of who's going to do it, should, at a minimum, from the department, include an identification of servicing department, who's performing the service. The servicing provider, is it the facility or is it the doc? The most appropriate revenue code associated with the CPT or HCPC requested. That's right. Make the person who's requesting it do some of the research before they give it to you. So if they tell you that this is for a professional service out of the ER and they put 450, flag, right? Because you know that something's wrong there, right? They're trying, but they still don't understand, right? When the addition is approved, and that's a big one, approved, someone's got to go through the process to make sure that this is right. We assign a unique item number relating to procedure code and revenue code, right? Ask yourself, at a minimum, am I doing any of this when this stuff happens? Most of the hospitals on this line, I'm betting money, do something similar to this. Some places will use a simple form, make it easy, makes it so that I have approval signatures, who wants it, I get them to sign it, date it, so that you can't tell me that you requested this 7 weeks ago and I've ignored you. No, it was yesterday at 7 p.m. We're just a little bit confused. It's not 7 weeks ago. Make sure that this allows you, when you put this on paper, we can work things out from a description standpoint, from a pricing standpoint, from a perspective of, are we really doing this, or is this the correct one for what you're talking about? So if they start giving you cath lab codes and you don't have a cath lab, you look at it and say, I think we got the wrong codes. Now, this is important because this starts at the department. Ask yourself, does the department get involved? If they do, give them something similar to this. And, oh, by the way, buy some CPT and HCPC books. I can't tell you how many facilities I go into that there's only 2 CPT books in the entire hospital. And when they bring them to me, they either just have that just bought code book smell, which means you just took the protective wrapping off, and they beat on it and stepped on it and dog-eared it along the way to make sure that they looked like it was working, or it's covered in dust because someone hasn't used it since 2009. Now, granted, they're expensive, but you need them, okay? So budget it and just have it as an ongoing expense item. You need to make sure you have that. Your item number. A lot of times people do not take advantage of your item numbers. Do you as a facility understand the total number of characters that are available for your item numbers? Can you use letters and numbers in the same code? If not, if I allow 8 digits and you tell me I always put 3 digits for my department, my response to you is then embed the CPT. Every chance you get, embed the CPT into your item number. It helps with your reports. It helps when they look in the billing screens and they can't necessarily see the assigned CPT, but they can see the item number from a billing or follow-up standpoint. The more specific you can make the item number to embed the CPT, the better for everybody, okay? It should be unique, so no 2 line items can have the same number. We know that. The system should prevent that at all costs. If possible, the item number should at least contain the department number followed by the CPT. Okay? If you can't use HCPC letters in your item number, make the decision that every letter will start with a 0. Come up with something simple, okay? Generally speaking, I like to use zeros because when I start getting into the other ones, I could start repeating other CPTs. And unless I've got professional anesthesia, the zeros make it a little bit easier for me to be able to ensure that I've got the right HCPC assignment in there. A unique item number is the only piece of CDM information necessary to tie all the revenue and financial reports together, right? So we should know that. Do we use that type of methodology in our reporting? Think of it this way. If we want the departments to use the reports and be proactive and look at utilization and stuff, it is terrific if you can print out your reports and then the CPTs are right there. Get your departments to think in terms of CPTs, not orders, not thingamajiggies, not blue tippy things. No. 96360, hydration. You want them thinking in terms of the numbers. CPT. Don't think in terms of words. This is where it starts. Ideally, the item number should represent both the department and the primary procedure code. Again, it's perfect for your reports as they come out, right? Simple stuff. If you've got 8 digits or 9 digits, some of you have 10. Some of you are allowed to use your letters in there. I mean, you got all this different stuff. So the question is why don't you? Look at your Chargemaster. When you download it, does the charge code thing kind of look like a roller coaster? It goes from 2 digits all the way down to 1 to 9, down to 6 to 5 to 7 again. Why isn't there unanimity in the assignment? Okay, you need consistency. Okay, any new code, do you have a policy for how that gets created? The answer has to be yes. Okay, uniform process of item number assignment allows for check and balance reviews in the business office. A lot of the stuff that we talk about in the Chargemaster, the easier you can make it on the business office, the better your reimbursement will be. Again, good Chargemaster, easy use in the business office becomes a profit center. Bad foundation, they're reinventing the wheel, they're a cost. What is yours? Ask yourself. Your description. Item description should contain the most pertinent information contained in the CPT or HCPC explanation. The description should be uniform for all occurrences of one CPT or HCPC within a Chargemaster. Now, I'm not saying in the same department, but you may provide hydration 96360 in 4 different departments in the hospital. Why should it be a different description from the ED to the OBS to the med-surg outpatient ambulatory infusion area? It shouldn't be. It should be the same description. Ask yourself, why? Okay? One of the easiest things that I find a lot is the same CPT, different description. Shouldn't happen. Okay? You let the CPT do the talking, make sure that the description is the same. CDMs are character limiting. So if you think about it, that you only have either 17 or 30 digits and characters. You've got to make sure that you use them to your benefit, okay? So many places will go through and they'll start all of their ERs. It'll say ER space, and then they'll put the things in. Well, I know it's in the ER because you used a 450 revenue code. Why am I wasting 1, 2, 3 ER space for my characters when I've only got 30 possibilities? And then you look at the descriptions, and the descriptions are horrible because they don't have enough space. Well, you're taking up, it's the same thing, lab. L-A-B, capital letters, start all of them, boom, space, or lab hyphen, or lab asterisk. I don't know why we do that. Do we not think that the people know that it's a lab? I mean, so we waste all these things, and then we start getting into some of the other ones, X-ray, just craziness, okay? So look at your Chargemaster. Do we do that? Ask yourself why. Well, we always had a problem with identifying where it was. Well, that means you got a revenue code problem. Right? It's not because of the descriptions, it's because of the revenue codes. Use them right. Proficiency in coding or anatomy and physiology is necessary to accurately truncate long CPT descriptions to most relevant information. Okay? Ask yourself, if I'm the CFO, do I have that appropriate thing to make the decision not to lop off the most important piece? How do I know in a 35-word CPT description out of the CPT book, what 40 characters out of the 35 words do I need to encompass? Right? Chances are you don't, and it's not a fair thing for you to know anyway. You need to use experts to be able to go through and answer that question, okay? So make sure that you're using the people and leveraging their knowledge. Don't just try to do it by yourself. So here we go. Again, the 22 CPT codes that we talked about before. Look at the differences in the total number of characters and words here. You have 147 to 215 to 193 to 257 to 247. Who's going to go through and truncate each one of those to 40 characters out of the 147? And what consistency are they going to use? Do we always start all of the upper GI, UPP space GI? Great, I just took a lot of characters and put them in. There isn't any reason why each one of these things doesn't start with UPP GI, right? So do I do consistency? Do I have a policy and procedure to guide that? Who's responsible for making sure that that continues to be the case? So when we have vague or incomplete examples from the CDM, so when we look at things, right, so I'll look at the stuff. So here's some stuff from actual CDMs that I pulled out, right? So 432, upper GI endoscopy. That description by itself fits over 40 different CPT codes. The same code, upper GI, and then we start getting into all the nice little characters, right? Now that one fits 22. I get a little bit more specific. All of a sudden now I've got that. It only fits 4. The person who knows what they're doing can get it down so that each description, for the most part, only fits 1 or 2, right? Who's doing it? How are they making the decision? And how can I be sure that they're doing it on a consistent basis and a compliant basis? Complete and accurate descriptions are hugely important, not only from revenue cycle reports that you create, but also from the business office. A lot of times they're on the phone and they may have printed out the UB, or they're working off a screen, and they just are dependent on describing to somebody on the other side of the phone what's happening with the service, and they're using the descriptions based on what's in the Chargemaster. Okay? So how much difference is it, when you look at it, if the billing person can go through for 43247, say upper GI endoscopy removal of foreign body, okay? I think I've got a pretty good chance of being able to communicate what that is without having to see the full CPT description. Same thing for the next one, upper GI endo removal of a tumor with forceps, right? Do I make it hard, or do I make it easy to get things paid? Likewise, when you start going through and you start doing things and say, oh, removal of foreign body, chances are they used a supply. Oh, do they take the foreign body? Maybe if it's a tumor removal with the forceps, are my forceps disposable? What do we do with the tumor? Do we always send it to pathology? Oh, let me look and see if I've got some of those charges on there. Oh, those are always send-outs. Okay, good. Well, when I have to wait for this one because I need to find out if it's malignant or it's benign, well, I got to put this claim on hold. I got to wait for the information to come back through coding to be able to decide on an appropriate diagnosis code. All of that can be simply discerned from the description, right? But do we do that? Do we use the descriptions to help? Or do we just put whatever we think in it because we got a lot of stuff to do, right? So it's very important. Spend time, so it is important what you call things, okay? So again, why is it important? It allows for quick and accurate code selection by the servicing provider, right? We want to make sure our encounter forms are as specific as they can be. You don't just have 15 codes that say colonoscopy. They're never going to select the right one. Allows for the check and balance at all levels of the revenue cycle. It should be happening on a redundant basis from beginning to end. Providers gain an understanding of documentation requirements that are different between the snare removal of a foreign body versus forceps removal of a tumor. All this stuff, they got to make sure that they're saying things correctly when they do their documentation. Coders can review and assess quickly. So all of a sudden, if I get better descriptions and better things that are available for my coders start doing their job faster, easier, and they can fire and forget, and they never got to see them again. The revenue posters can QA as they enter charges, right? All of a sudden, they're starting to QA things and understand things. If there's a denial, God forbid, follow-up and appeals team can quickly validate services were billed appropriately. Why? Because they can look at things easy, right? Customer service will have a more complete picture to respond to customer issues. Think how important that is. So I get the patient who calls up and complains about something, and I don't know what they did, because what they had is they had a look at say I can't even say the words versus upper GI tumor removal foreign with forceps, right? Then okay, so you had that. Okay, I don't even have to look at the CPT book. So much easier, so much more confidence starts coming through. The patient assumes that whoever they're talking to on the phone knows more about what happened to them than they do themselves. But unfortunately, someone in your business office, or maybe it's one of your registration people, they have no idea what happened to the patient. But if they look at the account, they should be able to very quickly discern based on the documentation of the descriptions, right? And if they do things right and you've got good revenue codes, they can quickly look and see, where was it done? Oh, I know in this facility, all ED technicals are 450. Let me look. Oh, you had this in the ED. Oh, 361. Oh, it's a 750 revenue code. I know the only time a 750 revenue code is used on an outpatient ambulatory surgery basis. Okay, I know where you had it. I know what you had. Now we can try to figure out, so why are you calling? What's of your concern? I mean, so they can very quickly do this if they're trained right, and they can be very much a value-added thing, and you start getting confidence to your patient. Say, hey, wow, these guys are cooking with gas. They know. This is great, versus I have to explain to you what happened. I have to explain to you that I had the call. Don't have the patients explain. Use the system for what it should be used for. Your charge amounts, right? So a lot of times, the only time we look at the charge amounts are when we do the 5% across the board, right? Great, okay. When we look at the charge amount, a lot of time, when you start downloading your Chargemaster, do you look at the charge amount field? Okay, if I sort by the same CPT, are they all the same price? If not, why? You know, when they're RADs and you've got LT-RT, right, and their ankle X-ray, LT-RT. One's $100, one's $125. You know, why are we making them pay more for the right? You know, it doesn't make sense. Happens routinely in most charge masters, okay? You got to be very specific and careful. The fees need to be uniform for all modalities within the service line. They need to be defensible based on cost and community, right? We don't want to be an outlier, but we don't want to be using the Harry Potter hat that says, you know, you go over and you say, all right, we're doing radio, pharmaceutical, isotope, TC99, and the thing comes back, $12. Great. I don't know what that means, but we'll put it in, right? We got to utilize a consistent multiplier reasonable for the department, you know, and then take into consideration transparency in billing practices. So think about this, you know, everybody is now a consumer. Patients treat your hospital like Walmart. You know, they're looking at it and trying to figure out, if I have a colonoscopy here, how much is this going to cost me, right? You got to be able to make sure if they call back tomorrow, it's the same rate, right? You don't want to find out that it depends on how they look it up, and it either could be $1,200 or it could be $1,800 or it could be on the Kmart Blue Aisle special. Today you can have it for $499.99 because that's what I saw in the Chargemaster, right? Prices are huge. You know, that's what patients get really upset with, right? So don't take for granted the importance from a consumer standpoint, the description and the price. Okay, hugely important. That's one of the things that they immediately look for, because all of a sudden now I'm paying out of pocket. When we set the charge amount, you know, determine the appropriate service component, professional, hospital, or if it's part of an alternate fee schedule, right? Review all fee schedules and contracts that pertain to the service under consideration. Compare that to the acceptable multiplier within the department. Do you have one? And to any information available for the competitor pricing. You know, do we have somebody that's calling all the hospitals to try to find out how much they sell their colonoscopies for? And if they have a bargain basement price, am I saying, oh, God, I got to undercut them? Oh, but it's still under Medicare? Crazy, right? You know, have your own things. Worry about yourself. Don't worry about the competition, right? You know, assign that fee. Review all occurrences of the code within the service component and the CDM. Make sure that you're consistent. And then update all for consistency, you know, if you find there's some inconsistencies there. Do you do this type of process when your fees, or do you use the Harry Potter hat, or do you use a spreadsheet that someone gave to you from a Blue Cross payer that had all the fee schedules, but that was 2007? Okay, everybody does something different, and we all try to make it as correct as possible, but we got to make sure that at least from a foundational aspect, it's set appropriately and correctly and dependably. So when we look at all of this stuff, hopefully what we're talking about here is we're saying, okay, when you look, and I've asked all these questions, everyone in the room's nodding their head saying, yep, got it, got it, got it, got it, got it. If we don't, go back to those individual sections and say, how can I try to implement these things? It is critical that you set your charge rate. You've got to have things that you can depend on that are consistent and will provide consistent results. Okay? If you've got variability in your charge master, you're going to have an extremely hard time being very profitable because you're going to chase your tail. Okay? Bare minimum. Assigned CPT should represent the most accurate code defining the service performed. Period. The alternate code should be only populated if they vary from the primary code activated for the item number. Where appropriate, they should identify the code required by the payer. Do we have anything in place to make sure that that happens? The revenue code assignment should be the most appropriate code for the service as represented in the cost report. Simple stuff. Who's doing that? Do we involve the department? Item number should be unique. Probably not a problem in your thing, but is it consistent? If I can use 10, do I use 10 every single time? Description should contain the most pertinent information. How do I make sure that that's the case? Is it just me in a room with the CPT book, or am I having a conversation with the coding business office and the department to ensure that I'm correct? The pricing should be fair, defensible, and consistent throughout a department or a service line. Simple stuff. Ask yourself, in my process for the creation of the most important file that I've got, that the bedrock of my entire hospital is built on, do I do those things? And how do I do them? Be fair to yourself. If you don't do them, great, great. You may do really well on 5 out of the 6 things here, right? Find out what you can do on that 6th thing, and then you've got best practice. There's very few hospitals that do. Why? Because they don't think they've got the time to spend to make sure that this is right. I will, on the converse side, look at you. I don't think you have the time not to do this. You have to. If you don't, then you're spending a lot of time fixing things that you shouldn't have to fix, right? You're going to pay the piper either way. I'd rather be proactive as we go through and do that. Remember, when we look at things, our Chargemaster, it's a lot like snowflakes, right? Every single one of them is different. All of my departments are different. The question being is, are the services that are performed, if I'm doing a service in all these different departments, are they reflected the same? I may have and treat things differently from a patient standpoint, but from a CPT standpoint and a description and a fee standpoint, are they the same? Okay? Make sure that you treat the departments differently, because you should, but from a Chargemaster standpoint, you've got to have consistency. Okay? So as we get ready for our next presentation, which will be on the 14th at the same time, we're going to delve into the best practice business office policies and procedures. Now, not surprisingly, a lot of those policies and procedures are going to build off of, wait for it, Chargemaster Foundation, because the more correct the Chargemaster is, the easier it is to have effective and implemented business office policies and procedures. So we're going to delve into that a lot next week, give you some tools to be able to try to help utilize that. If there are any questions on any of the stuff that we talked about here today, absolutely take a look at it. If you download your Chargemaster and you've got questions, whether it's right, wrong, I'd be happy to look at it. Just shoot me an email with the file in either text or Excel. I'll be glad to look at it. I'll shoot it back to you, tell you, if you're in good shape, or maybe offer some suggestions that you may want to look at or fix, and then give you some direction in being able to try to adjudicate that. So I'd certainly appreciate you guys spending some time in your busy day to do this. I hope that this is something that might be able to be used throughout your process, that you can take and print this presentation, educate people throughout the process, and by all means use this as an opportunity to move the ownership and accountability to those that need it, which is primarily your departments. So I thank you very much for your time and your attention. Please let us know if you have any questions. And at this point, I'll turn it back over to Leslie.
Thank you, John. And we don't have any questions in the chat box right now, but again, same thing I said last week, feel free to email me if you do have any questions, and I can forward that on to John to answer before the next presentation. On the screen, I have the links to register for the next webinar if you haven't already registered, and it will be next Wednesday, November 14th. And also the link is on the right-hand side of the screen for our online evaluation. Again, if you would like to receive ACHE credits, please take that survey and indicate that in question number 2. My email address is on the screen